Hello everyone, my name is Hassan Haidar and I will present for you the zygomatic complex fractures and I will talk about the first part of the orbital floor fractures. The zygomatic bone is a pyramidal in shape bone that consists of five parts: the frontal process, zygomatic maxillary buttress, infraorbital rim, zygomatic arch, and lateral orbital wall. The zygomatic complex usually fractures in the region of the frontozygomatic, the zygomaticotemporal, and the zygomaticomaxillary sutures, as you can see in this picture. It is unusual for the zygomatic bone itself to be fractured, but occasionally it may be, especially due to high energy injuries. Sometimes the bone may even be comminuted. The arch of the zygoma may be fractured in isolation from the rest of the bone. Classification of the zygomatic complex fracture. It can be classified according the involvement of the orbit or not into two categories. First one, fractures of the zygomatic body involving the orbit, which includes minimal or no displacement fractures, inward and downward displacement fractures, inward and posterior displacement fractures, outward displacement fractures, and comminution of the complex as a whole. The second category include the zygomatic arch alone, not involving the orbit, which includes minimal or no displacement fractures, V-type in fracture, comminuted fracture. The clinical features of the zygomatic complex fractures include flattening of cheek, flattening over the zygomatic arch, as you see in these pictures, swelling of cheek, limitation of mouth opening, anesthesia of cheek, temple, upper teeth, and gingiva, epistaxis due to disruption of maxillary sinus mucosa caused by fracture of the sinus wall, enophthalmos as you can see in this picture, which is defined as the posterior displacement of the globe. And in this picture you can see how the zygomatic bone is being examined by palpation using the two index fingers. As you can see here, one finger is lower than the other, which indicates a depressed bone. Other clinical features include periorbital circumorbital ecchymosis and edema, subconjunctival hemorrhage, tenderness and palpable separation at frontozygomatic suture, staph deformity and tenderness of infraorbital margin, ecchymosis and tenderness intraorally over zygomatic buttress, limitation of ocular movement. Crepitation from air emphysema also could occur due to involvement of the sinus wall with tearing of the lining mucosa, which allows air to escape into the facial soft tissue. Displacement of palpebral fissure and unequal papillary levels due to inferior displacement of Whitnell's tubercle with attached loquat suspensory ligament, as you can see in this picture. Diplopia is a very serious complication of the zygomatic fracture where the patient experiences blurred double vision. Also could occur and can be examined by force reduction test by holding the tendon of inferior rectus muscle and rotate the eyeball superiorly with the other movements and compare it to the other side. The imaging that used to assess the zygomatic bone fractures include the occipitomental Waters view, which is generally delineates the fracture pattern and displacement of the zygomatic complex, including isolated fracture of the zygomatic arch. Axial and coronal plane CT is the gold standard for radiographic evaluation of the zygomatic fractures. A submento-vertex view is helpful for evaluation of the zygomatic arch, as you can see here. In this 3D CT scan, you can see a well-demarcated zygomatic complex fracture, and in these coronal views, you can see zygomatic fracture involving the orbit. Treatment of zygomatic complex fracture. A variety of methods ranging from conservative treatment to surgical treatment by closed reduction of the fracture or open reduction with fixation can be successfully used to treat zygomatic complex fractures. Conservative treatment it is indicated when there is minimal or no displacement of the fractured bones and in medically compromised patients or more elderly for whom invasive surgical procedures and a general anesthesia are contraindicated. The surgical approach. Indirect reduction of a zygomatic fracture can be achieved by Gillies temporal approach, the percutaneous approach, buccal sulcus approach, Keene approach, and lateral coronoid approach, Cohen approach. The Gillies temporal approach is a popular and straightforward. It consists of an incision made in the temporal region and the temporal fascia is incised. Then an instrument is passed superficial to the surface of the temporal muscle and deep to the zygoma. The zygomatic bone or arch can then be elevated into a correct position using Rose or Bristow elevator. The position of the bone is confirmed by palpation of the infraorbital rim and the cheek prominence using the uninjured side for comparison. This video is demonstrating the Gillies temporal approach. An incision is made in the temporal region and the temporal fascia is incised. Then an instrument is passed superficial to the surface of the temporalis muscle and deep to the zygoma, to the site of the fracture. Then by using a Bristow elevator to reduce the fractured bone to its position. And by palpation, checking the correct position. The percutaneous approach is a rapid method most useful in non-comminuted fractures with medial displacement and no disruption of the frontozygomatic suture. A bone hook or a special screw is used to reduce the zygomatic bone. Buccal sulcus approach, Keene approach. An incision is made in the upper buccal sulcus immediately beneath the zygomatic buttress and a curved elevator is passed supraperiosteally to engage the deep surface of the zygomatic bone. Lateral coronoid approach, or Cohen approach. It is a simple method for isolated fractures of the arch. This approach consists of intraoral incision made along the anterior border of the ramus, through which an elevator is inserted lateral to the coronoid process, and the arch is elevated while the surgeon palpates extraorally along the arch. Open reduction and internal fixation. It is indicated in displaced fractures that are not stable after reduction. Comminuted fractures, fractures that are more than 2 weeks old, when orbital exploration is required due to the presence of diplopia or enophthalmos. The open reduction is followed by fixation of the fracture segments using transosseous wiring or mini plates and or microplates. The wires or plates can be fixed at frontozygomatic suture, infraorbital rim, and the zygomatico-maxillary buttress, and rarely at the zygomatico-temporal suture. Incisions for the surgical exposure of the zygomatic complex. Approaches to the frontozygomatic suture. We have lateral eyebrow, also called supraorbital eyebrow, as you can see here, and supratarsal fold, upper eyelid approach. Before doing these incisions, a special protection may be required by temporary tarsorrhaphy or a special shield protection for the cornea. Approaches to the lateral orbital rim, body and arch of the zygoma. We have lateral canthal incision and extended preauricular approach. Approaches to the inferior orbital rim and orbital floor. We have subciliary incision and subtarsal incision, infraorbital incision, and transconjunctival incision, as you can see here. Orbital floor fractures. The orbit consists of 7 bones. The outer frame of the orbit is the orbital rim. Inferiorly, it is composed of the zygoma laterally and maxilla medially. Superiorly, it is composed of the frontal bone. The inner frame is composed of the orbital walls, with the roof of the maxillary sinus and the orbital plate of palatine bone form the floor of the orbit, and ethmoidal and lacrimal bones anteriorly, lesser wing of sphenoid with optic canal posteriorly forming the medial wall, and the zygoma and greater wing of sphenoid forming the lateral wall of the orbit, and the frontal bone forming the roof of the orbit. Both the lateral wall and the roof are relatively thick, so the most common areas of fracture are the floor and medial orbital walls. Isolated orbital wall fractures occur in two ways, either blowout fractures or blow-in fracture. Blowout fractures include pure with intact orbital rim or impure with concomitant fracture of the orbital rim. In blow-in fracture, inwardly displaced fracture of the orbital rim or wall resulting in decreased orbital volume. It is not very common fracture. Clinical features of orbital floor fractures include periorbital circumorbital ecchymosis, subconjunctival hemorrhage, diplopia, limitation of eye movement especially in upward gaze, globe retraction on upward gaze, enophthalmos, surgical emphysema of eyelids, paresthesia within distribution of infraorbital nerve. As I mentioned in the previous slides, the entrapment of orbital muscles can be assessed by using a force reduction test, and it is essential to measure this interference with the orbital movement by means of Hess chart and to monitor any improvement or lack of it by repeating the test during the first 7 to 10 days after injury. For imaging the orbital floor fractures, plain radiographs are used but are unreliable in excluding such an injury or determining its extent. Instead, occipital mental view is used, as you see in this picture, which demonstrates the classical hanging drop appearance of a large orbital floor defect with herniation of the orbital contents. CT scan has the advantage of better bone visualization. Coronal, axial, and sagittal views are used to determine the extent of the defect. Thank you for listening.